of risk stratification. So just a reminder, here's who we are. The three of us work together with safety net organizations around the country and are delighted to be part of this process and really believe that this topic in particular is critical as safety net organizations really take the next step in, what's a very long journey in terms of effectively engaging around value-based reimbursement. Just as a reminder, here's where we are. As AJ mentioned, we are in session 3 of our 6-session series. We're going to talk a little bit about scheduling one-on-one time with us later. Next session is really entirely focused on discussion. We're going to be presenting at the end of today's session the case study that we are going to be teeing up for next session's presentation and discussion, and that means no homework for this week because we're going to have you guys working on one of 3 case studies and being prepared to talk about those in session 4. Then we're going to round out this series and talk about how risk adjustment is used in financial risk management and care coordination. And then, as AJ mentioned, the last session on April 11th will focus on a presentation of your group project back to the group. Okay, so today we're going to do a few things. We're going to talk a little bit about the homework that we asked you guys to respond to from the second session. I'm going to do a little bit of just a resetting or a recap on the risk framework that Starling is using in this series. And then we're going to talk about what some important components of risk stratification are and some of the things that we think safety net organizations need to be considering as they're putting risk stratification models in place. And then Sam's going to talk us through how safety net organizations are actually using risk stratification with payers, with their patients, and with their care teams. She'll also talk a little bit about how, I guess both of us will talk a little bit about how data is used to support the risk stratification process and, understanding that we're utilizing new types of data and structuring our data in new ways. It stands to reason that there's challenges with that, and so we want to kind of shine a light on, where things can get a little complicated as we go down this path. And then I'll round it out and introduce the case studies and any next steps. Okay, so let's do a quick review of the homework from last time, and we will, just kind of talk through and appreciate, folks who took the time to answer some of those questions. It gives a good sense of helps us better understand where folks are in terms of where they need to be, where the content needs to be. So one of our primary questions was, are you doing any kind of risk stratification today? We had one organization said, yes, we are, for our accountable care organization, and it makes a ton of sense because accountable care organizations are intending to wrap particular interventions and care coordination services for particular patient populations. And so in order to do that and to appropriately structure your interventions, you would need to have some sense of where your patients fell. We had another respondent say yes, by disease state, only to support quality improvement. Again, same type of situation. You want to be able to target your quality improvement activities as it relates to certain chronic diseases, and it's important to understand where your patients fall with regard to those chronic diseases. Yet another organization discussed the idea that, they're using some utilization data, probably in this case, to identify high utilizers or high-risk patients. And that's also a very common structural response to being able to identify those patients. So what kind of tools are you using to risk stratify? 25% of us are using screening tools. That's important. Sometimes screening tools include components of health risk assessment, but they also might include other specific data points that are important for your organization, the patients you're trying to utilize, and we definitely see screening tools and health risk assessments as an important part of the data gathering and phase of being able to properly risk stratify. Many of us are working with risk scores that are provided by payers, and we'll talk about that as well, and kind of what that means in terms of being able to respond to who the payers think your most high-risk patients are. And then other folks are looking at subjective assessments, and many times, and we'll also talk about the provider's role in helping to clarify risk stratification later today. So I would imagine that some of that subjective assessment has to do with your provider or your provider team's experience of that patient and where their needs might lie. And then other tools or other data points that might be assisting with risk stratification have to do with whether or not that patient presents a series of cognitive or physical or developmental disabilities that might appropriately place them in particular risk strata, and then also tiers within chronic condition health home programs. And many of us as safety net organizations may be participating in health home programs, and that our experience has been that most models for that really do look at a tiered response. Okay, so I'm going to do a little bit of a recap on the risk framework just to kind of remind us where we're at in terms of our discussion and how this is going to progress over the next couple of weeks. We talked a lot in our second session around this idea of risk adjustment. And just as a reminder, risk adjustment is really around the total amount of resources available to pay for care for a population of patients. This is largely set by payers and is a really important step in determining various targets that both providers and payers are utilizing in order to really make value-based payment models effective as it relates to total cost of care. And it's often the case that quality measures are maybe risk-adjusted based on particular conditions of the patient population, and that's really intended to not disadvantage providers who are treating the riskier populations. And we know this is an ongoing challenge safety net providers have as they're working with patients that really present a range of risk factors, both physically, medically, as well as it relates to social determinants of health. Risk stratification is about being able to put tools in place so that we can work proactively to identify which patients may require additional support in order to be able to better manage those inherent risk factors and help us by using data to identify patients who might be the most, who might benefit the most from those types of interventions. And it allows us then essentially to look at because we know we're operating with a scarcity of resources, how do we best direct our resources to the riskiest patients, and what might those models look like so that we can get maximum benefit across our total population of patients. Today's discussion is really going to focus on risk stratification, and in the next discussion, well, actually 2 discussions from now, session 5 is going to focus on, what are the sort of operational and clinical steps that we're going to take to address these underlying set of risks. So risk management really has to do with kind of what are our clinical care coordination intervention models that we use to help support these patients. And we're going to talk a lot in session 5 about how evidence-based guidelines and advanced use of data and models of care coordination and care management can support interventions that are successful in assisting patients in managing and effectively managing their risk. All right, so now we're going to focus a little bit on what recommendations, some of our experiences for how safety net organizations should be thinking about risk stratification. And we want to start with probably the simplest model that we can just to kind of demonstrate what we're talking about in terms of how these models are set up. So, it's one of the things we want to keep in mind is that we know this is broader population of patients, there are going to be multiple dynamics at play that will trigger different patients moving into different categories of the risk strata. And we understand that, but we want to just kind of walk through kind of the highest level of what we're talking about. So in this model, we have a population of patients. And the first question that we ask ourselves and of our data as we look at this patient population is, does this patient have a chronic disease? If the answer is no, that patient immediately moves into a low risk category. If the answer is yes, it triggers a series of additional questions. And the first is, are all of the patient's chronic disease well controlled? If the answer is yes to that question, then that patient moves into a medium risk category. If their answer is no, then they would move into a high risk category. So this is an overly simplified model to kind of show how the logic of some of the determining factors will play as we start to build out these models and start to identify where we're going to get the data to be able to respond and understand the answers to these questions. And we're going to talk a lot about the fact that as we're looking at more complex models of risk stratification, our experience has been that many of us within the safety net, and frankly even those who don't operate in the safety net, have a lot of challenges in making sure that their data is constructed and is put in place properly to be able to get the information we need to properly risk stratify. So a big part of risk stratification is really around understanding what the story is that the data that you do have can tell you about your patients, but also helps you identify what the missing data is in order to be able to do this properly. And the hard work really starts then in terms of identifying how we're going to put pieces in place to be able to get the type of data that we need in order to do the risk modeling. So when we think about effective risk stratification programs, there's a few things that we want to make sure that we're thinking about. The first is that it's really important that we have a clear clinical pathway that the patient's going to follow once they're placed in a risk stratification level. So what do we mean by that? What we mean is that, like, if we're going to go through the paces of identifying, where the patient falls, it's really important that we have some standardization and in terms of our approach to the intervention for that patient. That's really the point of what we're going to talk about when we get to risk management. But the point is that it's one thing to identify these patients, another to have an effective strategy for getting them into the right risk management trajectory. Second issue is that it's also important that initial assignment to a risk level be relatively objective and data-driven. And that has a lot to do with how payers are going to approach your patient population and what their expectations are going to be of you as you're engaging in these models to really meet the needs of the highest need patients. And so we're going to talk, and I think Sam is going to talk, or maybe I'm going to talk, both of us are going to talk a little bit about how to use data to do this. But that being said, assignment to an individual patient to a particular risk level can be overridden when the primary care clinician or the care team that's caring for that patient understands that there are contributing factors that would potentially place them in a higher risk category. And it's really important, and in all the models that we see effectively deployed, the provider or the provider care team has the ability to inform that process and has the ability to move a patient into a different risk strata, should that be what's best for the individual patient. And finally, whenever possible, that various risk levels are tied to different payment levels. And that really has to do with making sure that as we're putting in our care coordination and our risk management program, that the more intensive, more high-need risk management efforts that are being put in place are actually being properly resourced up by the payers. And a way that we see that often is in tiered reimbursement for, like, in terms of, monthly per member per month payments based on the acuity of a particular risk strata. So whereas a lower risk patient, provider might receive, let's just say, $10 per member per month. The sickest of patients with the most, complicated and complex health needs might even, might be, providers might be receiving, upwards of, $75 to $90 per member per month. So that's really about an appropriate level of allocation of resources and making sure that our interventions are able to bring the types of support that those riskier patient populations will need. Okay, so one of the things that we always want to make sure as we're thinking about how we're structuring our risk stratification models is we really want to start with the end in mind. In particular, what are the clinical pathways that we need to have in place in order to meet the needs of these populations? The end in mind in this particular example is, the goal is to reduce the number of readmissions for congestive heart failure by 50%. This might be a goal, for example, that a healthcare payer has contracted with you to try to meet. How you do that and what interventions and clinical pathways you put in place are up to you. But that's the goal that everybody has agreed that you guys are trying to achieve. So in this example, the intervention that the healthcare provider is looking at implementing has to do with things like in-home monitoring of weight gain to ensure that medication dosing is correct and that patients are taking their medications properly. So that's the targeted intervention, and the population is then all patients who are discharged from the hospital with a congestive heart failure diagnosis. So in this model, so what we have here, I just want to go back to this, is here's your congestive heart failure patients, and then you would be moving through a model that looks like this until you get to your high-risk patients who have been identified because of data that is collected during the intervention activities. Any questions on that? Okay, so that's your turn. Let's brainstorm, and this is the audience participation portion of today's webinar, so I really do want to hear from you guys. We have a lot of folks on the phone today. When we think about what the end goal is with some of our initiatives with payers, what are some of the things that make you more valuable to payers? And I want to actually spend a couple minutes here talking through what some of the interventions would be and who this particular patient population would be that we'd be trying to target. So you guys can use experiences from what you're doing now, if that is easiest. But what are some of the things that would make you more valuable to the payers that you're interacting with now in either some of the contracts that you have or some of the contracts that you anticipate? Anyone?
Oh, are we supposed to just say it or type it?
Say it. You can say it.
Right. This is Tricia Quinn from the DC Primary Care Association. Our Medicaid office and our Medicaid NCOs are really focused on the hospital measures relative to readmit and lane ED use, particularly.
Right. That's a thing. So if we were trying to, is there a particular measure, Tricia, that you guys would be looking at being able to impact an outcome on? And we can talk about what some of those interventions and patient populations might be for that.
Yeah, I think it's about percent reduction in, sort of getting a baseline on those things and then committing to a percent reduction in, say, lane ER usage in a particular patient population. Well, really,
Okay, so
all of them, it's really, they're not stratifying so much by risk for us. The measure is the measure, and you figure out how you get there. You know what I mean?
Yep. No, that's a perfect example of where the responsibility falls back on the provider to identify which patient populations are going to have the biggest impact we can identify who these patients are. So in that example, what are some of the things what tools and resources that would be helpful to you in order to be able to reduce those percentages and identify the patient population that you think are, going to have the biggest impact on those outcomes?
So we've had to have access to claims data so that we could even say who looking backward has really had these kinds of issues and kind of starting there in looking at, retrospective Medicaid claims data that tells us who's been to the ER, how many times, and why, and try to use that to some degree we have a lot more data that's looking backward, a lot less that is like sort of in the moment.
Right, and for folks that, most of us are in that situation. It's very rare that we have, good quality access to real-time data through health information exchange that gives us admit and discharge and transfer data. So that is a good place to start. Obviously we understand, that there's a correlation between folks who've been admitted and discharged and those who will be admitted and discharged again. So claims data is a good place to go in terms of a set of tools and resources. Again, if we had sort of magical resources through HIE that would give us access to more real-time data, that's another tool that can be utilized. Another intervention that with a group that we're working with has put in place has been partnerships between emergency departments and federally qualified health center care managers who are basically assisting with discharge planning on site, so that if those patients have a relationship with an existing health center, they can be scheduled for their follow-up appointment then and there. If they don't, they can be assigned to a federally qualified health center for follow-up, post-discharge. So that's a more intensive model of care transition planning, but, one where there's co-location and sort of open access to the scheduling of the participating health centers. That's another model. How about other folks? I'm sure that reducing hospitalizations or ED visits is something that most of us have at least been thinking about. Do other folks have examples or suggestions for the types of tools or resources or interventions that might make the most sense for that goal?
This is Redwood. I think we agree with the hospital conversation, the ED, input that was provided earlier. That was our input.
Okay, perfect. And then the patient populations, I think Tricia talked about this a little bit, who are the patients that we've had the greatest impact on. Again, it's going to be those high utilizers, and utilizing the claim data to be able to help identify who those folks have been in the past is predictive of what we might need to be looking at in the future. Okay, so thanks for that. That's helpful, and I think that as we go through and we think about, different models of risk stratification, the interventions are going to be driven by what those goals are that you're trying to achieve. The second thing that we highlighted was this idea that we want our initial stratification to be as objective and data-driven as possible. And there are lots of data sources that help us tell the story and help us structure a risk model by pulling from different data elements. What's important is that we are looking at doing this across our whole population on a relatively frequent basis, because we also, I think, intuitively understand that patients can move across risk strata, and that does impact not only the care they're receiving, but how we're being reimbursed to help to support them for that. And so it's important that we take a look at what different data sets can do to help inform that risk stratification model, and I think a lot of the data that we have at our fingertips can be helpful. It's just sometimes hard to structure it in a way to support the modeling process itself. But the five sort of big buckets of data that we have here are the ones that we see that are most frequently utilized by provider groups that are looking to create these risk models. Obviously, the clinical data that is inherent in your electronic medical record is critical. You're going to get a lot of information about who that patient is as it relates to the services that you've provided to them. Sometimes information in the DHR is very structured, and our experience has been sometimes it takes a little bit more mining to pull some of the key the data out of less structured EHR fields. But regardless, it's a very rich data source that we can use to identify some of the key elements that need to inform our model. The second area is around demographic data as it relates that may be captured in your practice management system. This could relate to things like, coverage status, geographic locations, other types of identifiers in terms of who that patient is relative to some of the key demographic factors like age, sex, gender identification, and race and ethnicity, as well as income level, if that's also the data that you happen to collect in your PMS. The third area has to do with social determinants of health, where Sam's going to spend a little bit of time talking about how this is used with particular models of risk stratification, and one of the case studies in particular focuses in this area. This is an area that more and more we see is important, not only for the risk adjustment process, which is what we talked about in question 2, but also really helps us to establish the types of relationships and interventions with community-based organizations that allow us to better meet the needs and social needs of our patients, so that our approach to our risk management programs are more comprehensive. But understanding what our patients are at risk for in terms of things like homelessness or food insecurity or interaction with juvenile justice system or domestic violence, whatever those key categories are that we think are critical to supporting their long-term success, also affect where we might place them in a risk stratification model. Social determinants of health can be captured in a number of different ways. We might be capturing them in some of our basic intake data that gets collected through our practice management system. Very often, social determinants of health are collected and informing our care planning as a result of health risk assessment. And so many times that data is collected through the assessment process, during intake, or each visit. And it's really important that as we're collecting that data, we're thinking about structured ways to be able to mine that data and run reports off of it. The last two categories, both utilization data and cost data, are largely driven by claims. And again, those may be areas where we are, where how to utilize that data and how to access it are new for us, but we know it's becoming increasingly important. As I mentioned, some of us might be lucky enough to have access to information exchange data that gives us more real-time data about what's going on with those patients in terms of their interactions with the broader part of the health delivery system around them. But it is important as we start to look at how we develop those risk models that particularly when we're talking about interventions or risk stratification as it relates to particular payer initiatives, that we're looking at the claims data that those payers are providing us and identifying what the right type of risk modeling needs to be based on the frequency of the data that we have and the quality of the data we're getting out of claims. These are the things that we sort of identified. Are there other data sets from the work that you guys are trying to do with your patients or with the payers that you're partnering with that you think would help you in the risk stratification process? I know behavioral health, for example, they have many screening tools that they use that may or may not be captured in their electronic health record. So that's one example of, another set of data that we would need to structure to be able to do some risk stratification around. What do folks think? Other types of data that you think would help you in your risk modeling and risk stratification?
I know one of the things that we've been exploring is the number of medications that patients are on. Higher numbers of medication obviously indicate higher risk, and so being able to have accurate medical pharmacy information is really critical.
Absolutely. That's a really, really important one. Sometimes that information can be pulled out of the claims data, and sometimes it's not as clean as that, but absolutely, I would say any data related to pharma is critical. That's a really good example. Okay. Yes, ma'am.
You may have already said this, I'm sorry, I got slightly bit distracted. On social determinants of health, is there a short list that has evidence in terms of most important to screen for? Is it the prepare tool? I mean,
Yeah, we're gonna talk about prepare as part of the kind of next phase of conversation. I don't know if there's, and I think prepare does a really good, for those of you who don't know, prepare is a national model that federally qualified health centers and community clinics are using nationally at trying to create a standardized tool and data set for social determinants of health as it relates to some of the issues around risk in these patient populations. I think prepare is a really good place to go in terms of looking at what some of those major categories are. Sam can talk about that a little bit when she gets to that portion. But some of it is also it may be very dependent on who your patient population is. For example, there could be, like when I use the example of behavioral health, there are lots of examples in terms of data sets that need to be collected, that influence, behavioral health care planning and resource allocation and things like that. But I think personally, I think prepare is a good place to look to. I think it's very highly relevant and indicative of what some of those key factors are. There are also several examples that Center for Medicaid and Medicare Services has been doing in a pilot form that look at key social determinants that they've identified, trying to direct some resources to support. In particular, the Accountable Health Communities Project, which is, soon to be announced and funded, hopefully, I think CMS is a funding project under the new administration, I'm not sure. But
yeah, we hear rumors, that's all.
Well, I did hear yesterday that healthcare is complicated. So that was encouraging. So, but in that model, they were looking at several factors: food insecurity, transportation, exposure to domestic violence. I'm forgetting the last two. Maybe Sam can remember.
Transportation,
food insecurity, EV.
Utility assistance.
Utility assistance. Yeah. So, things that basically would put somebody at risk for homelessness or, greatly impede their access to both, community-based services and healthcare intervention. But I think it's a good question. Yes, sir.
This is Aaron Milo. I just thought we'd add to that because we've been spending a lot of time asking questions about the evidence base and there's certain components of what we collect around social determinants of health have actually been studied rigorously and other pieces have not, which is unfortunate. There's a lot of room for research here, but we've been working real closely with Lauren Taylor, who was one of the primary authors of the Healthcare Paradox and has been focusing her research seeing the presence of or lack of case management or care coordination. And then from her perspective, there's a big drop-off in terms of utility to actually move the needle, but other issues that are still important, but maybe the research hasn't demonstrated as important come into income support and transportation. And then there are a variety of smaller ones as well.
I would definitely be interested.
Okay, yeah, we'd be happy to share.
Thanks, Erin. I appreciate that. I think that's good insight.
And then the sort of corollary to that, from a question standpoint, and I don't expect you to be able to answer it, Amanda, is, what are the appropriate interventions that health centers can do on addressing whatever they identify? Really trying to figure out where is the biggest bang for their buck in terms of intervention. I get that that's not necessarily what we're going on today, but it's a question.
No, I think it's an important one because one of the biggest challenges we see groups kind of grappling with is kind of how to start and how much to bite off at one time. Our advice is I almost like to sort of say, let's look at these as mini like PDSA cycles. Let's try to identify populations where we can test out some of these interventions and use data to determine how effective we're actually being before we try to push something out to a huge, overwhelmingly large proportion of our overall patient population. So, we sort of counsel and favor strategies that are really going to focus on, at least initially, I don't mean to be so crude, but almost the biggest bang for your buck in terms of being able to turn those cost and quality curves quickly and kind of learn from that in terms of what types of interventions then could be built off that existing infrastructure. And this is where we think it's really important to be able to hear from safety net providers about what's worked and what hasn't worked. And so much of it depends on, who the patient population is that you're trying to reach and what some of the regional constraints or assets might be. So if you have, for example, a group of providers that has a strong relationship with a local hospital, they're going to be a lot more effective at certain types of interventions than, a group of providers who don't have the same kind of access to that kind of a partnership. If you have a set of providers who have access to a certain type of specialty service that can help, support that patient population, that other regions or other providers may not have that, the best we can do is really to sort of share what has worked. To the point that was made earlier, the pet issue that I always bring up is this issue of clinical pharmacy. There's, a lot that can be done around really working around medication management and using those claims data and EHR data to be able to really target some specific interventions like that can have a pretty substantial impact, both in terms of cost and quality pretty quickly. But if you're not in a situation where you have access to a clinical pharmacist, that's not going to be an intervention model that's going to work well for you. So we really want to encourage you guys to be talking about these things and thinking about how to, how to share the successes you have had in a way that's going to help folks think about what is the most impactful. But yeah, I wish there was a longer list of let's do these 18 things and, we would have achieved it all. But it's a little bit more complex and has a lot to do with individual relationships with payers and other parts of the delivery system. Okay, so no matter what the data tells us, our providers and our care teams are going to inherently understand things about our patients that are going to affect where we think they truly fit on the risk, sort of within the risk stratification structure. Some patients are just straight up hard to manage, and others have contributing social determinants or social factors that may not show up in sort of that objective data pool that stratifies people. And so we think it's really important as you're putting these models in place that providers have the ability to, at least to some degree, to move some of these patients around to higher levels of risk if they feel that there's the ability to be
be able to properly swat them and support them with interventions that are going to help improve their outcomes. It is important, though, that you set some parameters around that, because if we don't use some level of sort of systemization around how we're identifying that, it could negatively impact how you are able to pull funding down from your payers and the contracts that you've had, and it also could really disrupt staffing infrastructure that you have in place. But we do think it's important to be able to leave that level of judgment in place and allow the model to be responsive in that way. We talked about this a little bit earlier, but it is important to be thinking also when you're putting your models in place that different levels of risk are very often going to be tied to different levels of payment. This is important in APMs that include care coordination payments. You almost always will see those as tiered as it relates to the risk of the patient population that the interventions are targeting. It's invariable that lower risk patients are going to have usually lower resource needs, and higher risk patients are going to have higher resource needs. And we want to make sure that we are putting models of intervention in place that are properly resourced up. And then what that means is how we budget our staff and how we establish our panel size in terms of our care coordination infrastructure is going to be critical to that. Alternative payment models that include shared savings or capitation usually have some of this factored in already. So patients that have more with more risk have more premium, and therefore you have the ability to garner more savings theoretically from those patients. And it is really important that we keep in mind that, what we understand about our initial payments is really going to inform how we can better manage them. So we want to make sure, again, that we're going into these arrangements in a way that doesn't off the bat disadvantage us, but that we really understand why the premiums were set where they were and how we need to manage to support that. Okay, so at this point, I'm going to turn it over to Sam, who's going to talk to us about some of these models in action and what we've seen safety net providers, how we've seen them respond. And Sam, I'm not sure if you need me to professional I can.
Yeah, okay. No, I can do it. We're actually going to talk about one of the types of models that here is a per member per month care coordination payment. I don't know if any of you have experience with the Section 2703 health home pilot as a part of the Affordable Care Act, but I'll talk a little bit about the experience in Missouri, and I think we have a provider from New York on the phone, so I don't know if I know New York's had a health home initiative too, so we're interested to hear what people's experience with this is. But the Missouri Primary Care Health Home Initiative is a pilot funded under Section 2703 of the Affordable Care Act. It targets patients who are high risk due to certain conditions. So if they have two or more of the conditions listed here, diabetes, heart disease, asthma, BMI over 25, tobacco use, or developmental disabilities, they are eligible to receive services under this pilot program. And it's a program that the goals are similar. I'm sure we've all, these are the same goals we see with most pilots: reduce top hospitalizations, reduce ER usage, improve clinical indicators, and reduce costs. And the intervention is identifying a group of providers who are eligible to deliver really intense care coordination to these targeted patients based on intensity, with an intensity of service that's based on their risk score. And the way Missouri targeted, those of you who have had experience with these type of pilots know that there's some sort of ceilings and qualifications set by the federal government, and then states have a certain amount of flexibility in how they implement the program. And the way Missouri chose to target this is tiering their different target populations in three sort of categories. So one, the first category was 1 chronic disease and risk for a second. Second category is 2 chronic diseases, and then the most intense, highest level of acuity was 3 or more chronic diseases. They associated those different target populations with a payment that's tied to the patient's risk level. They're precise; their exact dollars aren't publicly available, but those 3 risk tiers had different payment levels tied to per member per month care coordination payment, and intensity of that care coordination scaled up corresponding with risk. Then the other piece on the provider end is that providers who want to participate in this program and receive that per member per month payment had to meet certain qualifications. And so the state that they defined what it would meant to be a health home to these patients at risk. The staffing that the health home had to meet was also adjusted for the relative risk of the population. But these are kind of the roles that Missouri required the different health homes to have in place, and the ratios that they had to prove they were able to accommodate. So they needed a health home director, a program director, a nurse care manager, access to behavioral health consultant, a care coordination, a provider champion, and then certain administrative and information technology targets that they had to meet as well. And I think in Missouri, Amanda, that some of this was tied to the NCQA PCMH. I think that Missouri State Medicaid Department used the NCQA PCMH program as sort of a starting point. So the qualifications aligned with something that many of you have already probably had experience with. I think the 2703 program is a 2-year pilot, and I know Missouri's out of that time period now. So they're able to show some outcomes. So the program had 2 sort of provider populations that they were working with: primary care providers and community mental health providers. And across those 2 groups, they served over 40,000 people. They had some significant cost reductions for their Medicaid expenses, and then they saw success with each of the indicators that they were looking for in terms of lowered hospitalizations and ER utilization, and then improvement in these quality indicators as well, or the blood pressure, LDL, and diabetic outcomes. So before we move on, I'm wondering if any of you have been able to have some similar experience, whether a 2703 pilot or a risk-based care coordination pilot, either with your Medicaid partners or with a private payer.
Hi, this is Sue from Family Health Care. We haven't had either of those really. We'll have Medicaid come in and do an audit, right? Or we'll have someone from an insurer come in and do audits. And then they'll send us the results, right? And it still is, hey, what are you going to do to fix this? Even if we meet with them, it's not like we sit down and say, we can manage this group, and if you've got case managers on your payer side, that you can help manage that group, or how do we work together to actually have it done? We've had those kind of informal talks, but it never goes to anything formal enough for us anyway, to really be able to identify that in this population of patients that you are insuring and that we're caring for, that you've reduced hospitalizations by X amount. So we never know our value to the insurer, and they never know our value to them. And so I can see that would be important, but we're doing everything that's on the screen now. We're on our side, we're thinking we're reducing ER utilization. We know where we are with uncontrolled. We know where we are on blood pressure, LDL levels, A1Cs. We've just got data like crazy. But it's really, how do I harness that data with the right people in the right way to know? So that's just my comment.
No, thanks. And the audits that your payers looking at both utilization and these quality indicators? Are they more is it HEDIS focused audits that you'd be getting information around diabetes and blood pressure and more less utilization information and more just quality of care indicators?
Yeah, less utilization and more of the HEDIS measure.
Yeah.
This is Aaron in Iowa. We do have 2 health home programs here in Iowa that are 2703 sections. Health home programs, one focused on behavioral health and one on chronic conditions from a more, I guess, traditional medical perspective. We have one FQHC that's integrated health home, which is the behavioral health one, and we have almost all of the others are chronic conditions health home programs. I think they've been successful here, but one of our challenges is that they're very rigidly run by the Medicaid agency, and now we have managed care as of last April, and the managed care companies absolutely hate them, particularly since they can't approve or disapprove them. They have to accept them as the Medicaid agency brings them online, and so in the last month, 67 new health home programs were started by one of the major hospital systems in the state. But it really does come out of that rigidity, and one of the reasons why we're interested in learning more about this is we like to streamline some of the ways that the state, the Medicaid agency, the MCOs, and us think about our patients and risk stratification, and then think through the appropriate tiering and quantify what those costs might look like. We have some rules, barriers, which would require a thought change, and the state has just gotten so prescriptive that we feel like we have no flexibility to do what we really like. And we're also kind of moving, those health programs are all run at the local FQHC level, and then Megan and I represent the network level. And so kind of finding a way to standardize some of these processes at the network level, and then how that relates to some programs that at this point anyway are administered and resourced at the local level. That's some of the things that we've been thinking about and grappling with. And I think also importantly, the behavioral health home program is a mandatory program for Medicaid patients here in Iowa. If they meet qualifications, they're automatically enrolled, whereas the chronic condition health home program is a voluntary program, so that also causes friction among provider groups.
Thanks, Erin. And when you say it's rigid, is the program rigid in terms of provider qualifications or patient qualifications into the program, or both?
Kind of both. So one is trying to who they think are most important and qualify from a patient perspective, and then the other piece is more on expectations around how you will service patients and how you report that back.
Right.
Is key.
Okay.
And especially when you have our encounter-based payment methodology, which is good, but also complicates things as well.
Great. Which makes sense. Thank you. Thanks for sharing. It gets complex really quickly. That's a good story to share. Okay. So I'm going to go through some of the challenges that you can encounter when you're looking at the different data areas. We're working with those different data areas that Amanda described earlier. I'll move through it pretty quickly because we're running up on time and we want to save time to talk about the case study before we close today. But we'll stop for questions after we walk through this. So this is these multiple data sources: clinical data, demographic data, social determinants of health, utilization, and cost data. These are your core building blocks, which you start with when you're wanting to start to implement a risk stratification program. And one thing we're going to share after this session, it may look familiar to some of you because I think we're working with you on it, is a quick tool for sort of getting your arms around what data sources and the quality of the data that you may have. So it's kind of a checklist for you to go through and look at all of the different pieces that fall within those data buckets that you may or may not have access to, and it's a quick rating of how accurate and robust you feel that data might be. And it's not meant to be a really thorough, time-intensive assessment. It's just a quick sort of brainstorming activity to give you an idea of where you are right now, what you've got to work with right now. And it may be useful with the case study, and I think it'll also be useful with the final project that we'll work on in a couple of weeks. So if we look at your EHR data, your EHR structure is some really key. It's probably the most the largest set of data that you have to work with. You have demographics, you have your diagnosis and procedure codes, medications, medical and social history, your history physical exam, and screening tools if you use those, which we know some of you do. And so it's your most important source to starting approaching your risk process because you're in complete control over this information. So you can add elements that you identify you want. You have the most impact on improving the quality of the data that you can access. And you have full control sort of once you've established your risk stratification program. You can design your EHR to give your providers prompts and alerts and things like that that are structured in the way that you want your risk stratification program structured. So it's really the core data set that will support your risk stratification program. Most of you probably also have demographics data that's in some type of practice management system as well, which could be your EHR, could be distinct. So you may also collect some of these basic demographic information like race and ethnicity, language, veteran status, poverty level, housing, other things that sort of start to approach in that more social determinants of health space. Now, social determinants of health, this is really, we'll talk a little bit about the Prepare tool later, but this is an emerging field in terms of standardized data collection. I think it's not news to any of us that this is really core to improving health outcomes and really important, especially with safety net provider organizations. The risk adjustment and risk management models that sort of overlay the healthcare system as a whole don't really account very well for the complex social needs that the populations of safety net providers serve. So, this is a big interest, particularly of providers like you. We had some questions earlier about sort of what the most important social determinants of health data indicators might be. And I think, one thing that's challenging in this space is that there's not as widespread standardization that both payers and providers can agree on in terms of how to approach collecting and stratifying social determinants of health data. And the closest that we think we can get to that is something called the Prepare tool that was developed by a group of safety net providers. NAC is the National Association for Community Health Centers. I'm sure many of you work with them, and they've done some work in this area to kind of get some standardization and get as much information possible behind what core social determinants of health indicators are important to collect, how to collect them, and they've consolidated that in a toolkit around this Prepare tool. And I think one of the questions earlier was about which social determinants of health indicators are most important. The Prepare lays out a set of core measures and a set of optional measures. And I think it's small on the screen, but the core measures are race, ethnicity, migrant and seasonal farm work, veteran status, language, a couple questions about housing, education, employment, insurance, income, sort of food security and material security, social integration support, transportation, and stress. So those are the core measures that NAC urges you if you're going to start tracking social determinants of health in an organized way. And using this Prepare tool, they feel that it's important to collect information on those core measures as a starting place, which is a lot. And then they have some optional measures regarding incarceration history, refugee status, and domestic violence that you can add on to. And if you follow, I want to stop there and see if anyone has experience in using this Prepare tool or another sort of organized way of collecting social determinants of health information. Hi, this is Redwood. Oh, so go ahead. Sorry.
No, go ahead. This is there for my line. Okay, enough. You should go for it.
Oh, that's okay. We like that. So in California, so we are piloting Prepare. We have
social determinants of health work group that we formed at the end of last year. And so we are talking about the Prepare tool. We have 4 health centers that have already begun pilots, but not a mass implementation yet. And so we've gotten as far as deciding that this is the standard we're going to use since it's a national vetted tool, and that we're going to agree to a certain set of those questions, the required set, not the optional set of questions in the Prepare tool. And then yeah. No, go ahead. No, I was just going to say we're, yeah, so I guess we're, moving forward. I think the health centers are at different paces as far as how many patients they're going to, are they going to just focus on a particular set of patients? Are they, for a small health center, going to just do it for everybody? How's that going to look? Who's going to do the questions? What format are they going to be asked in? Is it a person that's asking them? Are they going to use iPad? All that kind of stuff is kind of what we hope to discover in our social determinants of health work group.
And is this just a local effort, Teresa, or is this part of the larger payment demonstration that's going on at a statewide level?
Well, I think both. Redwood is part of the NAC Blue Shield funded project where 5 consortia in California are implementing Prepare. So we've got 2 health centers that are going to go a little more deep in this process and contribute to NAC's toolkit on how this work is done. But we've got other grants. Our Health Center Controlled Network grant has a component of helping health centers standardly assess for social determinants. So that's, a reason to do it. We've got a complex care grant that's also got a social determinants component. So everything's sort of pointing to this. And then we got a county grant for CMSP that for the remaining uninsured, but it's also about assessing standardly for social determinants in Sonoma County. So a lot of different initiatives pointing this direction.
Makes sense. Thank you for sharing. Okay. Any more comments or questions on social determinants of health data? Okay. So if we're moving into sort of utilization and claims area, utilization is looking at healthcare usage patterns, and the most useful. I think utilization and claims are where it gets really, I think, challenging to get access to what you need that's accurate in a timely basis. So the most useful utilization data comes from real-time sources like HIEs or interfaces between different kinds of providers. Like, for example, between you and your local hospital, so that you know when your assigned patient is admitted to an ER or to a hospital. And it can be claims data can be really valuable in giving you information about utilization patterns, even if it doesn't break out the detailed costs. But I think that, I don't know if any of you have, maybe we can talk at the end of this because we're running up on time, but, I think that it's really challenging to get this information accurately and in a way that's manageable and actionable for you as providers. In claims data, when we move into this area of risk, it all really comes down to claims data. So I think this is going to be increasing in terms of how you manage this, but claims is something that you sum over a period of time to look at total medical expense, and that's really what it comes down to, is managing the total cost of care. You can sift through these claims data to identify specific patterns of use and target. If you were working in a shared savings arrangement, you would develop your strategy for how to bring down your total cost of care by identifying certain areas like IDD use where you could develop an intervention strategy to target that particular pattern of cost and usage. You can look at prescriptions. We talked a little bit about that earlier. And you can dig into your ICD code and CPT code to get more information on the care that your patients are using and why. when we look at sort of the multitude of challenges that you see when you're looking at these types of data, they kind of fall into 5 categories: quality, consistency, timing, how complex your stratification logic model is, and disparities between the data sources that you have control over versus the ones that you're dependent on another body to give you. So with data quality refers to whether your data is accurate enough to drive your risk stratification logic model. And any of the data sources that we've talked about can have significant quality challenges. So billing data is usually your highest quality, given that it drives your payment, and EHR quality is improving a lot over the last 5 years. But you can still have challenges in both of those areas. So there's a variety of issues with claims-based data that we see in risk stratification. So payer claims data is only as good as what your payer is receiving, and especially in safety net providers where we may have different sort of billing requirements, there can be a lot of inaccuracy with the ICD-9 and ICD-10 codes that have been used. AHR data is a lot more challenging because, I'm sure this is not news to any of you, you probably all have experience with this. There's free text fields, there's changes that you've made to your customization that you've made to your EHR that can result in variation across these areas. And there's, different places that certain data pieces can live. So this example of a diabetic foot exam, your providers can be, if you identify that as a piece of information that you want to extract from your EHR, it can be inputted in multiple different places. So does it live in your physical exam field? Is it a VLC? Is it in medical history? Is it in the diabetes management template? So it's just an area where you could see that this could be recorded for patients in a variety of different ways. A good test for approaching how to start to dig into your data quality is, can your data resolve a yes or no answer? So does your patient have cardiovascular disease? So a good place lets you know you're in a good place with data quality. Patient has an ICD-10 code on a problem list. ICD-10 code is correlated with congestive heart failure. That is a cardiovascular disease. So yes, that answers your question. Yes, your patient has cardiovascular disease. A bad data quality example is your provider enters follow-up from a CHF hospitalization as a reason for visit in a free text field. No ICD-9 code is assigned to the problem list, and you live in free text, so it's very challenging to pull that in to a report. So that patient would not, in a report, appear as though they had cardiovascular disease. So you would not get the correct answer to a yes or no question. Some strategies for addressing poor data quality is to base your risk stratification model only on structured data fields. So, and then working with providers who are using your AHR, sort of education around the standards and where you want certain data fields to live and why. Writing out your logic models and documenting every data element that drives the yes or no questions that you've identified as being important to your model. And then when you have no other option, you can consider using a risk screening template where you identify these core questions that you want to be asking. Does the patient have cardiovascular disease? Yes or no? So that you kind of start from scratch. Your second problem is with data consistency. So this is a challenge associated with missing data when you don't have a clear way of knowing that data is missing. So any of your data sources used in risk stratification can have quality challenges. Claims data, if your patients are bouncing around between uninsured and insured status, or between different coverage options, they'll have gaps in the claims data that you may have access to. And your EHR data may not clearly identify a difference between a positive finding and negative finding, or no assessment made at a certain time. So a test to sort of dig into this issue is of whether all your patients have been assessed. stratification model would be able to take that unknown, not assessed option into account. And a place that leaves you in a poor data quality position with regard to data consistency is only having a yes or no question. Who does the patient live with? Is there someone who prepares the food for the patient? You don't have an option to know whether you've asked this question or not if you only have a yes or no field. Homelessness might be a good example. Yes, the patient is homeless. No, the patient's not. You wouldn't know if you hadn't asked the question. So all patients who you haven't assessed yet may fall in that no category, and your risk stratification model would be flawed. Some strategies for dealing with poor data consistency are really considering that null state. What does that mean in regards to your logic model? And trying to run reports to dig into how large your data consistency problem might be, how many no's or nulls do you have, and that can flag whether you would want to develop a model that really relied on that data element. And then, same with data quality, a screening template and asking an exact question, maybe where you want to start to really improve your data going forward. Now with data timing, your third problem is data timing. So data timing issues occur when the results become less relevant over time. So if the most recent A1C score you have for a given patient is from 4 years ago, doesn't matter. Do you include it or not? Your patient needs a new score, but if you're starting a risk stratification model and trying to start from scratch, you need to account for timing issues like that. If a patient was hospitalized 12 times a long time ago, is that useful information for knowing whether they'll be hospitalized in the future in 2017 or 2018? So a way to approach the data timing issue is setting finite limits on your logic test. So has the patient utilized the emergency room? A good way to phrase those questions are within a time bound. So has the patient visited the ER in the past 12 months? How many times has the patient visited the ER in the past 12 months? Bad data timing questions leave out the time bounds. They just ask generally, does the patient utilize the ER for ambulatory sensitive conditions? Some strategies for dealing with data timing issues, making sure all your logic tests have those clear time bounds, structuring your reports and other recall tools to have the same appropriate time bounds so that your data is correct when you're analyzing it, thinking through it, having a discussion and a plan for how you want to handle old, outdated data, whether it's relevant or not, deciding whether it's relevant or not, and utilizing reports to find patients who like that outdated A1C. So what that result might tell you, it may not feed into your current risk stratification model, but that patient should probably get an up-to-date A1C test. And then the fourth piece is getting into the complexity of your logic model. So this risk here, 4 risk tiers, low risk associated with no chronic disease, and completing PHQ-9 or PHQ-2 and Q9, no evidence suppression, mild risk associated with 2 to 3 chronic diseases or 1 chronic disease in the BMI over a certain level, tier 2 moderate risk, current smoker, tier 3, 3 or more chronic diseases, family history of colorectal cancer, BMI over 30. So this may have made sense when this group developed these different tiers, but it's going to be challenging for this provider group to work with because it leaves certain gaps. So like where do people with evidence suppression fall? We see that in tier 0, but then it's not referenced again as you move up the acuity scale. Where would people with 1 chronic disease, just 1 chronic disease fall? It's not laid out here in their criteria. So these may have made sense when they looked at they developed their intervention strategies for each of these tiers, but it's going to be challenging for them to follow it in practice. It doesn't tie together totally. So when you're building that logic model initially, start simple and add as you go. Think about how your stratification levels are going to align with what you're able to do in practice. can test the application of your rules and really see where things are going to fall through. And then our last issue with data discrepancy is discrepancy between your data sources. So you're going to see this a lot when your two data sets are in conflict. So a patient assigned to you by a payer, but has never come into you, or an EHR, you show that a test was done, but your payer isn't aware of it. So you have a discrepancy between your EHR data set and your payer claims data set. Discrepancies, when you are facing these, you may need to prioritize. You may need to decide which is going to be your primary source versus a source that you're going to deprioritize when there's conflict. So dealing with data discrepancies, you want to overlay your data when it has the same information. So lab results in your EHR and state claims of that lab can both be representative of that lab data piece. Payer-created data is probably the best when you're looking at things that have happened outside of your organization. So a paid claim on hospitalization is going to be a more accurate data point than patient self-reported data for something like that. But I'm sure that there are exceptions to this that you may have seen. And EHR data will almost always be necessary for your qualitative assessment. I think, Amanda, since we're up on time, we'll skip this discussion piece and just move into the case study because we want to save time for some questions and I introduce this for you. So I'm going to hand it back to you.
Thanks. So I'm going to just talk us through very quickly what the case study assignment is for our next session. We've tried to keep this as digestible and relevant to folks as possible. So our goal with the case study is really to give you some real-life examples of how you as safety net organizations might be asked to respond to different risk scenarios with your payers. So the way that the case studies are going to work is that each group is going to be assigned a scenario to talk about during the group discussion. We've put a set of 4 questions in place that are going to be relevant for each of the case studies. So you'll be responding to and discussing your observations and responses to those questions, regardless of which case study that you have. And you should be prepared during our next session to talk about the discussion that you had had. You don't necessarily need to submit anything back to us before the case study, but if you find it useful to kind of document your responses and some of your observations ahead of time, we encourage you guys to do that, but we're not requiring you to submit anything to us. So really quickly, I'm just going to talk through what the scenarios are. The first scenario is a managed care organization case management payment for highest risk patients. This is very similar in some ways to the health home model that Sam just shared with you, but under this scenario, your organization's been approached by an MCO to provide targeted case management for your highest risk patients. The MCO intends to provide a per member per month payment to support those enhanced care coordination and care management for those patients. So the questions that you'll be asking or responding to, how would you target the patient population? In a scenario, what do you consider to be the most important factors for determining high risk? The second question that you'll want to be responding to is which data and information will be used to risk stratify your patient population. The third question focuses on, are these risk stratification data and information available to you now? If so, where do you pull it from? And if it isn't there, what types of processes or workflows would you need to put in place in order to gain access to that data? And in particular, are there external data sets or information that you would need to incorporate that you don't currently have now? And then the last question is, which tools, resources, and infrastructure will your organization need to put in place or use to target interventions for those patient populations? And you'll want to creatively think about, if you were approaching this particular scenario, what types of staff, technology, other types of resources would need to be in place. So that's the first one. It focuses on case management payments from an MCO for high-risk patients. The second one, same question. The scenario is a little bit different.
focuses on a shared savings option for patients with congestive heart failure. So under this scenario, your organization is participating in a regional care organization, which is like a regional, almost like a regional ACO, to better coordinate care transitions for patients who've been hospitalized or CHF. The RCO has developed a payment model that provides payment for particular patient or performance activities, and has also plans to distribute back shared savings to your organization who participate in the RCO. So given those scenarios, you would go through the same questions in the same fashion. And then the last scenario focuses on a regional collaborative to support social determinants of health. Under this scenario, your organization is participating in a regional collaborative of healthcare provider organizations and community-based organizations to work to better link patients with community resources, behavioral health services, and healthcare providers to meet their comprehensive needs of the patient, including their social determinants of health. Under this model, some funding is being provided by the state to support community health navigators to help link patients to various parts of the system. So a little bit different approach in terms of what the interventions are going to look like under this model because it's relying on sort of cross-system collaboration through navigators. But the questions are the same because you still need to be able to identify these folks that put in place the ability to stratify their risk and relate that back to the types of community resources and healthcare services that they might need. So those are the three scenarios. Like I said, all the questions are the same. We've spent, based on what we knew about your organizations, we did the best we could to put to you guys in assign these out to you. We did have a request that Meaningful New York move to the first scenario. Is there anybody from the second scenario or from the first scenario who'd be willing to swap places with them and focus on the RCO option instead of the PMPM option? Anybody, either Northern Nevada, Lake County, or Redwood, that might be willing to swap with New York? No? Okay, so New York, go ahead and move into scenario 1, and that means we'll just have 2 groups in scenario 2 and 2 groups in scenario 3.
Hi, this is Susie from Redwood. We're having a little technical problem. Can you tell us what our scenario is? We might be willing to.
Yeah, your scenario is this one, Susie, is the PMPM for the high-risk patients.
And what's the scenario you want us to swap into?
The shared savings for congestive heart failure.
Now, we're fine with swap.
Okay. All right. So RCHC and New York will swap. And again, AJ is going to be sending out an actual document that has the scenarios on it and the questions, so you don't have to try to do your work from the PowerPoint. But you don't need to necessarily submit anything to us. Just come ready to really discuss that. The second piece we want to give you a heads up around is in our next session, we're going to be focused on, we're going to be introducing the final project to you guys. So after we talk about the case studies, we'll open up a discussion and share with you guys what the structure is of the final project. One of the things that we have found to be helpful in the past is to be able to set up some very brief one-on-one time with you guys to talk about your final projects in advance of presenting them at the last session. So, embedded in this slide deck, as well as in a follow-up email you're going to get from AJ, or you may have already gotten it. I'm sorry, can't always tell what's going on in advance. That's my limitation, not AJ's. It's going to be a link to a Sign Up Genius online sign-up form where you can sign up on behalf of your team for an not really an interview time, but let's just call it an interview time for your team to meet with Charlie to talk through what your thoughts are on how you want to structure your final project. So
The actual interview times won't take place until after we've had our next session, but we'd like folks to get it signed up sooner rather than later so that we can really hit the ground running after we introduce the case study to be able to talk through some of those things with you as you're getting prepared for the final session. So between now and the next meeting, if you guys could access the sign-up changes link, sign yourself up for a quick touch base with Starling. We'll send you a calendar invite that has the dial-in information, and if you have some time in advance to meet with your team to think through that, great. Otherwise, we can maybe talk through and brainstorm with you while we're on the call. So, any questions about the prep session? I know. Okay. Well, thank you guys so much. It's really encouraging to hear that so many of you are really starting to endeavor into some of these areas where we're having to think about how to use our data to put some risk models in place so that we can think about what types of interventions are necessary for these patients as we start to engage in new models of care delivery and reimbursement with our payers. As we mentioned, session 5 is going to focus on what those risk management programs look like and what some examples are that we've seen organizations like yours implement in order to be able to effectively manage these patient populations and be able to pull down the commensurate reimbursement that goes with them. Looking very forward to a discussion next week or next time around the case studies. You guys are a great group that really does a good job, I think, of really bringing your individual experiences to the group. And so we really hope to have a dynamic, interactive discussion next time. So thank you.